Okay, and I will also admitting some more people in here. Okay. All right, so I'll start the session now. So hi, everyone. Welcome to the Opioid Agonist Treatment workshop. And my name is Tam, and I'm the research coordinator of the UBC Addictions and Concurrent Disorders Research Group. And I'll be the moderator of this session. And it is, of course, my honor to have with us two esteemed experts in the field of psychiatry, Dr. Maximilian Meyer and Dr. Martha Ignaszewski. Please correct me if I'm like really butchering your name. And of course, I'll first introduce Dr. Martha. She's the clinical lead at the Substance Use Response and Facilitation, or SERVE services, and the director of postgraduate training in child and adolescent psychiatry at BC Children's and Women's Hospital. She's also a psychiatrist and education lead at the Complex Pain and Addiction Services at the Vancouver General Hospital. She'll be presenting on OAT for adolescents and young adults from a Canadian perspective. All right. Also next presenter will be Dr. Max Meyer. So he's the doctor of medicine at the University Psychiatric Clinics in Basel, Switzerland. He's going to present on the novel and diversified OAT strategies to reach youth at a risk from the experiences that he has in Switzerland. So I'm thrilled to have both of them here as our guest speakers, and I look forward to learning from your insights and expertise. And so now, Dr. Martha, I will now pass it on to you to start off the session.
Thanks so much, Tam, and thanks everybody for joining us. I'm just going to start with a very brief land acknowledgement. And sorry, you can't actually see that very well. I'm calling in today from the ancestral and stolen territories of the Coast Salish people, the Squamish, Tsleil-Waututh, and Musqueam Nation, which is where I both work and live, have the fortune of living as a white settler. I'm not going to talk a lot about my bio. Tam did a nice job of that. I do have some relevant disclosures, and they're specifically around speaking honoraria and a research honoraria for some of the work that I do around working with individuals who use drugs, especially opioids and opioid use disorders. And I'm going to start with a very brief outline about some trends of opioid use in Canada and the US, and then focus a little bit further on opioid overdose rates in British Columbia and the US. I'm going to talk a little bit about pharmacotherapy for opioid use disorder and sort of set up a little bit of a foundation in terms of medications and pharmaceutical strategies that can be accessed, and then transition briefly to talking about concurrent disorders with some take-home points, and then pass on the presentation to Dr. Maximilian, who will be able to actually describe some pretty innovative strategies that are happening where he lives and works. So this is some recent data from a survey that occurred in British Columbia in 2018. And what it shows is that youth experiment with substances, and we know that to be the case. And marijuana and alcohol tend to be the substances that youth use most often recreationally. But a number of youth in their teen years will actually experiment with substances other than alcohol and marijuana. And prescription pills tend to be the most common. And what this slide is showing is that by the age of 18, from the respondents, about 14% of youth will have trialed prescription medications, which includes things like painkillers. And that's what the majority of these youth are trialing. This is, I think, important for us to think about is that 80% of youth who access opioids actually tend to get these from friends or from family medicine cabinets. So that's something that I think is important for us to think about. Coinciding with increased awareness about the risks of opioids and the opioid overdose crisis, the amount of prescription opioids being prescribed in Canada has been decreasing. And so what we're seeing is from 2013 to 2017, that's been decreasing across all age ranges as well as in the general demographic. And that actually parallels reductions in trends in non-medical opioid usage. So across Canada, about 3% of Canadian youth use opioids. We see that younger ages tend to use fewer opioids compared to higher ages, and there's a little bit of a skewing towards males. These are similar numbers to other places around the world, where in the US, about 4% of youth are using non-medical opioids, just less than 4% in Australia. And what the graphs on the right-hand side are showing is that actually use of unprescribed opioids or unregulated opioids such as heroin or other narcotics other than heroin have also been decreasing. So all of that I think is really good, but what it doesn't really set us up for is this understanding of why rates of hospitalization have been increasing and why youth overdose rates have been increasing. So in Canada, we see that youth have experienced the highest rate of hospitalization related to overdose and substance-related harms, currently at a rate of about 1 in 20 hospital stays in youth relates to substance use. And many of these youth have recurrent rates of hospitalization. And we're doing a better job of recognizing the risk of youth substance use and actually screening for it. And so we actually see that the diagnoses of opioid use disorder in youth have increased quite substantially in the last decade and a half. If we look more granularly to British Columbia, which is where I live in practice, what we see is that youth overdoses, while the absolute numbers are relatively low, they have increased very dramatically over time. So before the opioid overdose crisis was declared in 2016, there were, between 3 and 6 overdoses occurring on an annual basis. And that number has increased 5 to 10-fold. And by 2022, there were 34 youth under the age of 18 who lost their lives secondary to opioid overdose. And if we look at the 19 to 29 demographic, we see that this is the patient population that makes up about 1/3 of all of the losses, which is really devastating. Put another way, this is some demographics from the BC Centre for Disease Control. There was a period of time in 2021 that opioid or illicit drug toxicity death actually became the second cause of mortality for youth aged 10 to 18. And what we saw is actually illicit drug overdose can be twice the rate of other causes of death in teenagers. And what is not as clear on this slide is actually that suicide and accidents, which are the other 2 top causes of death in youth, also may be increased in likelihood of occurring or may actually be causative factors for these experiences. Certainly, we know that youth from certain backgrounds are at much higher risk. So Aboriginal youth are particularly vulnerable, and that relates to social and economical disenfranchisement. So among First Nations youth, prescription opioid use is actually the second most frequently used substance, second to alcohol. And I mentioned an average rate of about 3% of prescription opioid use in Canada, Australia, a little bit higher in the US, but that number increases to about 10% in Aboriginal populations in Canada. And we see that there's a disproportionate rate of overdose in these individuals. Other individuals who are disproportionately affected by the opioid overdose crisis and mortality is individuals with from sexual minority backgrounds, such as LGBTQ youth, as well as gender nonconforming youth. Not surprisingly, street entrenched youth are much more likely to die of a drug overdose. And children who come from backgrounds and families with substance use disorders and have experienced adverse childhood experiences are also at very high rates of developing substance use disorders, as well as mortality. I think many of us are going to be familiar with graphs like this, which show the increase in overdose rates over the last number of years. This is specifically from the US, and it shows that there has been initially a doubling and more recently a quadrupling in overdose deaths in the last 20 years. And this is driven by fentanyl, other synthetic analogs, and highly potent opioids in the illicit drug supply. And that's what we're seeing here as well. So substances such as fentanyl and carfentanil and other adulterants, which we're starting to see more commonly. I trained in the US before relocating to Canada a handful of years ago. And so I look to national organizations that have developed guidance about how we should manage opioid use disorder in youth. And the American Academy of Pediatrics was one of the first agencies in the US to actually put out a policy statement indicating that youth should receive the same services that are offered to adults. And that includes medication-assisted therapy, which involves medications for opioid use disorder. That's language used in the US, and in Canada, things like opioid agonist therapy. And the unfortunate reality is that that doesn't happen very often. And I'll talk about that in just one moment. So there's a huge recognition that medications for opioid use disorder, and I'll talk about what those are in just a moment, are absolutely beneficial for youth. And there should be more pathways to make care more accessible. And in particular, there is demonstrated safety in addition to the known efficacy of these medications. The other piece that is maybe a little bit different in adults, though quite a big overlap nevertheless, is actually the prevalence of psychiatric comorbidities in youth with opioid use disorder. And depending on the treatment setting that you're in, that could be anywhere between 50% up to 90% of concurrent disorders. So when we think about management, pharmacologic management of youth opioid use disorder, what are our options? Well, in the US, there are 3 medications that are used very frequently: buprenorphine, naltrexone, and methadone, that all have slightly different courses of, mechanisms of action. And have slightly different FDA approval, but general effectiveness. And that's a little bit different. Oh, some of my, there we go. Slightly different approaches compared to what we have in Canada. So we certainly do use buprenorphine naloxone, which is a partial agonist and is probably identified as a first-line therapy for management of opioid use disorder in youth. That's because of its pharmacologic properties and ceiling effect, which means that it tends to be safer for use. We do not have extended release naltrexone, and oral naltrexone is not used for management of opioid use disorder in Canada. We do use methadone as well as other medications such as extended release oral morphine, which is also known as Cadian, and quite rarely are options such as safe supply or intravenous opioid agonist therapy accessed. Increasingly, we've been using extended release depot buprenorphine, which is a once monthly injection and is particularly youth centered because it can allow for improved adherence, reduce the necessity of going to the pharmacy on a daily basis. And all of these strategies have been researched and demonstrated as being evidence-based and successful for patients that we work with here in British Columbia. I'm just showing some of the case reports that we've looked at and published over the last few years. Despite recognition of this, despite there being an opioid overdose crisis and recognition of that in 2016 in Canada, and these guidelines put out by the American Academy of Pediatrics in 2016, what we see actually is that few youth are really accessing appropriate therapy. So this is a study that's a couple of years old right now, but it looked at Medicaid enrolled youths between the ages of 13 to 22 in the US who were seen in emergency departments after non-fatal opioid overdose. And I think they identified just shy of 4,000 youth and young adults. And what the researchers here found was that after opioid overdose, less than a third of youth received timely addiction treatment. Many didn't receive any addiction treatment at all, actually. Some received behavioral health services, but less than 2% received medication-assisted therapy for opioid use disorder. That comes out to 1 in 54 youths who received evidence-based pharmacotherapy. Another way that this is shown, and this is in a treatment population, so youth who may be presenting to outpatient clinics like primary care settings or to pediatric settings, very few youth, even those with diagnoses of opioid use disorder, are receiving evidence-based gold standard treatment. So 1 in 4 youth receive buprenorphine or naltrexone within 6 months. And these numbers are even lower from youth from marginalized communities, so Black youth, Hispanic youth, and Indigenous youth. And that's really troubling because, as I mentioned, there's extensive research basis and clinical basis for the use of medications for opioid use disorder. We know that these can be life-saving in that they can reduce the likelihood of opioid overdose. It supports retention and care, and also is associated with reductions in transmissible infectious diseases, can also help support mental health access to care, as well as other social determinants of health, such as housing and family involvement. What's pretty interesting is that in British Columbia, this qualitative interviews actually suggest that youth in BC, and especially in Vancouver, are able to access opioid agonist therapy relatively easily, but there are a lot of expressions of concern about the addictiveness. And so many youth who are interested in starting treatment express that they are interested only in maintaining treatment for a brief period of time and really wanting to come off of it in the not too distant future. So that really begs the question of how we support youth, how we develop our treatment strategies to be able to support access, as well as longer term retention and care, as well as focus on pieces outside of the pharmacotherapy. I think here, the way that I really think about that is trying to understand from a youth-centered, patient-centered understanding, thinking about some of the drivers of use. So we're not just looking at opioid use disorder through a biomedical model, and certainly not exclusively using opioid agonist therapy to satisfy an opioid deficiency model, but trying to talk with the individuals that we're working with. And many youth will say that they use substances to feel good, to feel sociable, to relieve stress and cope with negative situations. And we know actually that there's a huge overlap that I alluded to in concurrent disorders in youth. And so youth who use substances, in particular, overuse their own prescription medications or non-medical use of prescription medications are much more likely to do that with an identified mental health condition relative to no mental health condition. And some of those numbers double, as we can see towards the bottom of the chart. So I alluded briefly earlier that the concurrent presence of a psychiatric illness in the substance using population, and conversely, can be concordant up to 90%, especially in adolescents who are treatment seeking. And in the US, very few receive appropriate treatment, and that seems to be the case in Canada, but I don't have statistics that is as readily available. And as I mentioned, that's alarming for a number of reasons, because we know that untreated mental health can increase the likelihood of continuing to use substances, and also can interfere with actually appropriately accessing treatment adherence to medication, as well as to outpatient appointments. And so I offer this article to show that all-cause mortality is reduced for individuals and emergency department visits and hospitalization visits are also reduced for individuals in whom a concurrent and integrated treatment approach is taken, rather than exclusively thinking about pharmacotherapy for the substance use disorder. I'm not going to talk a lot about naloxone, but I cannot speak about opioid overdose and youth management without thinking about this. And one of the treatment shifts that I have done in the last couple of years is, at this point, I am now offering any youth that I see with any substance use, whether that's alcohol or cannabis, a take-home naloxone kit, because youth who use any substances are at higher rates of experimentation. And may not know the substances that they are using. So this can be a life-saving mechanism. I also offer these to their parents, and I think that we should be making this readily accessible for the general community. Some of my thoughts about how we actually improve care for youth with opioid use disorder is actually to shift the focus from treatment to think more about prevention and early intervention. And that can happen inside and outside of the healthcare system. So where I live and work in BC, one of my big initiatives recently has been to try to increase screening in the health system, and that's happening on for patients admitted to inpatient psychiatry at my hospital. But we need to be able to do that in the community through primary care, and over time to be able to do that in the academic system as well, where youth who may be particularly vulnerable or higher risk may be able to access some support earlier, and then allowed to connect that to the healthcare system as needed. Global public health messaging. So I'm really excited for Dr. Max to give his presentation and let us know about what Switzerland is doing. They are far ahead of us in terms of managing opioid use disorders, as well as the 4-pillar approach to treatment. And over time, I think we also need to ensure that we're having low barrier access to integrated concurrent treatment, and really to focus on longer term engagement. And some strategies to do that includes engaging youth and peers with lived experience, so that youth who and adults who start in treatment are engaged and have appealing and enticing services, so that they actually stick with treatment over time. My take homes, I'm happy to share my slides as well as the references here. And with that, I will pause and pass the presentation on to Dr. Max. Thank you.